Okay, good afternoon, everyone. My name is Anna Marinic and I'm a project manager here at Monash Partners. And I wanted to welcome and thank you for joining us today for our virtual webinar on CogStack and artificial intelligence to revolutionise use and access to electronic medical record information. So I'd like to start by acknowledging the traditional custodians of the land on which we are standing, and in the spirit of reconciliation, I pay my respects to elders past, present and emerging. I extend respect to any Aboriginal and Torres Strait Islander people joining us today. Wherever you are, I acknowledge and pay my respects to our First Peoples. So before we start the formal presentations, I just wanted to cover off some general housekeeping. So we are recording today's event and it will be made available on the Monash Partners website online. Please add any questions that you have to the Q&A section and any comments in the chat section. There is time allocated after each of our invited speakers' presentations for any specific questions that you may have. So please do use that Q&A function. Also, towards the end of this session, we have a panel presentation where all of our invited speakers will be available for further in-depth discussion and to cover off any additional questions that anyone may have that we haven't had a chance to address during the forum. And just finally, before we get started, I wanted to share the agenda just so you had a line of sight of the flow of today's event. So kicking things off, we'll hear from our Executive Director, Professor Helena Teede, who will talk about Monash Partners and the Learning Health System. Then I'll be presenting just a general and quick overview of CogStack before I'll be handing over to our individual speakers who are representing our various Monash partner organisations who have been directly involved with implementing CogStack. So you'll hear firsthand from them about their implementation and specific use cases. And as I mentioned earlier, we'll round this out with a general panel discussion and more opportunity for Q&A. Okay, so I would now like to introduce Professor Helena Teede. Helena is the Executive Director of Monash Partners Academic Health Science Centre and also a Professor of Women's Health and the Director of the Monash Centre for Health Research and Implementation, and is an endocrinologist at Monash Health. So I'll throw over to you, Helena. We got Helena online, B.
Sorry, she was here just a second ago. One moment.
Okay. Sorry, everyone. We'll just give Helena a few moments to join us back online. So while we're waiting for Helena, as I mentioned earlier, we have allocated plenty of time for questions after each of our speakers. So there is that Q&A function in the chat. So please do add your questions as we go along. And also too, if you just have any points for discussion to promote cross-fertilisation of ideas, we really want this session to be as interactive as possible. So again, feel free to use that chat function as well. Okay, so what we might do is, I think Helena might be having some technical difficulties. So we might just pivot that famous, and we might just skip ahead to my part of the presentation. Okay. All right, so ahead of actually giving you an overview of CogStack itself, I just wanted to take a brief step back and frame my presentation by discussing more generally natural language processing and its particular relevance in healthcare, so where it potentially fits. So with the digitisation of healthcare and the rapid adoption of electronic medical records and EHRs, this has really created an explosion of data that's typically collected in silos. In addition, nearly 80% of the clinical information collected in EMRs is unstructured, and it's in a format that health information technology systems can't use. Now, it's the unstructured data that contains a wealth of insights into patients that typically isn't available in the structured record. Now, extracting valuable insights from unstructured data has been difficult because it typically involves quite complex and time-consuming manual data analytic processes. Now, natural language processing is a promising solution to this problem, as it creates quite an efficient and effective way to understand and analyse an enormous or large amount of quantities of unstructured data. Now, when used in healthcare, natural language processing algorithms can search the unstructured electronic medical record content, including clinical notes, patient histories, and other documents. So using advanced medical algorithms and machine learning techniques, NLP has the potential to harness relevant insights and concepts from data that was previously buried within the electronic medical record. So the novel piece of technology that utilises natural language processing, because there are quite a few out there that we have been piloting as part of this project here, is called CogStack. So just by way of background, the tool was actually originally developed by bioinformatics and health informatics researchers at King's College London in the UK. And there the platform has been successfully deployed and implemented in multiple NHS services, and its implementation is now being scaled across the NHS more broadly. So here, the piloting, we've got funds, we've received $1.9 million of MRFF funds to apply CogStack to various health service settings and essentially pilot the technology. And I've just got the logos here of our collaborating partners, each of whom you're going to hear from directly today. So doing a bit more of a deeper dive into CogStack itself. So CogStack is an application framework that allows extraction of information from unstructured data sources. It's open source, it's a low cost and easily deployable solution that is designed for healthcare environments. It's designed for working with electronic health record databases. One important point to note is that it isn't a single piece of software. So it's actually a combination of multiple component modules or microservices running and communicating together to create what we call the CogStack ecosystem or platform. Now, this platform is comprised of these multiple open source technologies, some of which include enterprise search, natural language processing, analytics and visualization technologies to unlock the health record to assist in clinical decision-making and research. So if we have a little bit of a look of an example CogStack setup here. So here you can see that CogStack retrieves and extracts information from both structured and unstructured health data, and it utilises embedded analytics and visualisation technologies to really assist in unlocking that untapped value of data from routine clinical care. So typically the data in electronic health records, they're quite often incomplete. They contain large quantities of unstructured data. They're stored in proprietary systems and in different formats. And essentially the challenge is that most of the information, it's just written in a form that's really difficult to retrieve and analyse and learn from. And as a consequence, you've got this, wealth of information that's potentially available within the health record. It's often inaccessible and underused. So quite often we're reporting against just that structured data set. Now, CogStack applies NLP and AI technology that allows you to extract the information regardless of the format. So whether it's structured or unstructured, in PDF, scanned images, text fields, and it can read and then understand that information. So as part of this project, as I mentioned, we have various organisations who have trialled CogStack, and they're going to share their implementation use cases, each of which are in very different settings. And in addition, you'll also hear from Monash University, who have supported each of these organisations in their implementations and in piloting the CogStack platform. So that's it from me. I think Helena is now with us. Hi, Helena. So I will stop sharing and reshare, and go back to the start.
Thank you, everyone. Very sorry, I had technical problems with Zoom, which I think many of you did on three devices. So anyway,
I'm going to put it up for you, Helena.
Great, thank you. That'd be really good. So I'm on sabbatical at the moment. I've just been overseas for 6 weeks, including working with the King's team, and I'm back for 2 and then going back again. So I'm just going to give you a little bit of context. I'm going to let you listen to the experts who've been doing this on the ground, and great to have the other panelists with me. So the idea here is we're talking about artificial intelligence to revolutionise the use and access of electronic medical record information and other information. In this particular case, we're mainly talking about CogStack, but the learnings are obviously broadly applicable. As Anna's noted, this is funded by the Medical Research Future Fund, and indeed we have several other large-scale pending grants that are actually also associated with this. Next slide, please, Anna. Thank you. So just quickly in the context of this grant, so Monash Partners, which is one of the organisations that I have the privilege of working with this team to lead, is an NHMRC accredited centre. There are 10 of them, and 7 of them are what we call Advanced Health Research Translation Centres. We are actually charged with embedding research into healthcare. And to some extent that involves flipping the paradigm. And one of the learnings we've had from this and FIRE and other projects that we've worked with our health partners is that typically researchers will often write a grant and simply say the health services will do X, or the health services will provide the data, or the health services will deliver Y, usually without speaking to the health services, without assessing the capability in the health services, without necessarily setting up the research support that the health services may want to access, or respecting the capability the health services have in data. And also not necessarily flipping the paradigm to what the health services are going to need, because if we want this to work, it needs to work for the health services. They need to be able to implement it in their own unique environment, but then sustain and maintain it, which means it has to resolve their own problems. So over our period of time in Monash Partners, one of the things we've learned is, especially in data, all the stakeholders need to be in the tent, right up front, co-designing the problem and the solutions. And that often the typical research paradigm of the clever academic coming up with a great research program actually isn't necessarily what we need here. And so one of the other things about this journey we'll hear from our partners today is to recognise that paradigm flip in what they're talking about, and the great support that the university with Adam Morrison team have actually been able to provide to the health services. But essentially that's what these partnerships are supposed to do. We're responsible for embedding research into healthcare and for the translation of evidence into practice. So thanks, Anna. And that point, that lovely slide, that diagram there is, it doesn't matter how you paint them, the reality is our lived experience is full of silos. We have a very large university with 10 faculties. Within the medical faculty, there are 10 schools. Within the schools, there are lots of sites. And then you've got different faculties, and then we've got our health services. So our job is to be the sand or the glue between them. So our purpose is to connect researchers, clinicians, and the community to innovate for better health. So our purpose is around health impact. And there's over 3 million Australians cared for by our partners. And as I mentioned, we're there to hoist people onto the scaffolding or provide the landing net around those silos. Thanks, Anna. So our focus is very much around health outcomes, and one of our strategic priorities, in fact, our top strategic priorities from our plan endorsed by the Council, is to improve health outcomes through data-driven innovation and improvement. You will notice that is not to do research with data. It is to improve health outcomes with data, and research is one of the vehicles for that. So I won't go into this in detail. Many of you have heard this before, but it's the context for CogStack. One of the bodies of work we were funded to do through the Medical Research Future Fund is to look at the processes by which we can actually utilise data more effectively. And one of the things we know is if you go straight to the data, or you go straight to the IT system, or you go straight to CogStack, and you think about what that looks like, you probably, in fact, in all intents and purposes, will be very, very slow at driving health change and health impact, because it becomes yet another silo. And what we needed to create with a lot of effort was a learning health system that was evidence-based. So we went through a very rigorous process I won't go through now, which created how to do this from an evidence point of view. And there are 4 quadrants. The first is evidence from stakeholders. If we don't understand the need, the problem, and the priority of the people who have to implement these systems, then it is not effective. And so it's really important we attract the evidence from the stakeholders about what they need, and they will tell you their own priorities when we go through that. The second is evidence from research. In the healthcare context, evidence from research is very rarely used to inform improvement, and partly because these worlds are siloed, but bringing that in is critical. Evidence from data, which is evidence from practice, and that's what CogStack is an essential part of that. And the last one is, great, you know what the problem is, you know what the evidence is, you know what the data is, but most people then don't implement change. And so it's putting all of that together in an iterative cycle that's really powerful. I've just spent the last 6 weeks talking about this in the in the UK, and they are so much more ahead of us in terms of conceptualizing this, that actually it's being pulled into all sorts of contexts, whereas everyone in Australia is, oh, we don't quite understand that. And we're just starting to go on that journey. But one thing I would say is it's really important to understand CogStack is in a context of a broader problem and needing to work together. Thanks, Anna. Next one. Great. So it's really around actually forcing people to do co-production and focus on what the problems are and what the needs of the end users are when we do our research to enable change. So it's got all the necessary elements to bring this to fruition. Next slide. So as Anna mentioned, we have a grant for this, but we've also got probably, I suspect, up to about 10 million now in other submitted programs to work to support and enable the partners to deliver the sorts of projects and solutions that they need. And so it's about innovating, adapting, and one of the reasons CogStack is important is it's open source. And Adam and the team at the university with the health partners have been able to adapt and tailor. Most of the commercial products that are out there are not necessarily like that. They're off the shelf. This is what they are. They're very expensive. They have ongoing license costs, and they don't allow this degree of adaptation that's occurring. At the moment, they're open source, and 90 to 95% of the learnings are coming from King's. The other 5% are coming from Monash. And we are actually the only group to use it internationally. The collaborators are down there, as Anna has said. Next, please. So CogStack is AI, as Anna said, that retrieves and extracts information from a range of different sources, which can be utilised in a range of different ways, and you'll hear about that from our partners today. It's got embedded analytics and visualisation technology. It's not necessarily the only product or the best product, but it is open source and it is tailorable and it is well advanced because it was designed to solve the problems of the health system by people working in the health system who are really keen to primarily solve and improve health outcomes. So it's not been designed from a commercial perspective. Next one, please. So obviously you can do free text searches from the electronic medical records, but you can also search about a whole range of different data you'll hear about. It does allow you to have timely risk monitoring and alerts, and indeed it's being used in all sorts of sophisticated ways, increasingly, especially in COVID in the UK. And it can really give you quite a lot of insight of, because of the stack of technology to be able to do that. So CogSack was developed by King's College London. I met with their team and I'm about to meet with them again when I go back, and really very focused on greater public good, which is often what you see in UK. They are currently looking at the fact that their model is open sourced and will remain that way. There will be some commercialisation overlay, but they're going to try and avoid any lack of flexibility. And the commercialisation will likely be for modules, and we're working with them around that at the moment. It is being implemented through the foundation trusts and being scaled, and we, through Monash University, are the only external international partner, and as I mentioned, are informing this work. Next one, please. Multiple project plans. One of the things about this is actually the governance. So whilst Monash Partners attracted the grant funding, it doesn't come to us. The only funding that comes to us is in fact for Anna's role, but our role is to provide the governance and the sand between those silos and to genuinely focus on making sure this is meeting the needs of the partners and the end users. So we've also seen the work around some of the ethics and liaised with a great team at Monash Uni, including Adam and others. And then you'll hear about the use cases from our partners. Next one, please. So we're going to focus on CogSack here, but we have also been scoping some other work, and I'll talk about that on the next slide. So these are the 3 use cases that you'll hear about. So it's aged care and dementia, hospital setting and primary care. I put the slide up not so much to talk about the detail, but to highlight that these are what came from our partners. We didn't write a grant about putting CogStack into health services, or it was more about what they needed the solutions to look like. And I'm sure Nadine will also talk to you about the fact that they've innovated with some private industry partners as well. And I think we've learned a lot through the project in the co-production context, meeting the needs of the partners. Next one, please. So the other body of work that's happening in this grant, which won't be talked about by the others today, is we have also gone out nationally and internationally, and we've explored who's using artificial intelligence in healthcare. So we've done a fairly strong exercise to look at who's doing that nationally. That work is currently being published and also feeding into different bodies of work, including by the Australian Clinical Trials Alliance, who are very interested in the application of AI in clinical trial recruitment. We've done the scoping, we've done the surveys, now we're doing the qualitative interviews with all of the groups who are using AI. There are not many, and there is not much activity nationally, and it would be fair to say that from what we can tell today, these three use cases and this activity will be the one of the more developed examples of the use of AI and NLP in Australia. So well done, guys, before you even tell us what you're doing. As I mentioned, we're already working with Kings around what a business model might look like, and our partners are already pulling this in for other use cases. I think one of the most interesting is one that is actually happening in the UK at the moment, and we hope will happen here, which is creating a business model to be able to fund staff in the context of our health services, and that's around coding. So in the UK, they've started a program where they've been using AI, basically CogStack, to do all their coding, which determines the revenue for the hospitals. And they've generated massive reductions in cost for people and very significant improvements in coding efficiency and effectiveness. So one of the things they've then been able to do is justify more money for their data teams in their health services and a more prominent role. And that becomes really important, as our partners will tell you, because they only have finite teams. So I'm going to stop talking now, but I just wanted to give you the context of why this was the Monash Partners project and why it's been run differently and flipped to a conventional, I'm a researcher and the hospital's just going to give me their data, to actually house the research helping the health services to answer their problems. So back over to you, Anna, to pass on to the next speakers.
Great, terrific. Thank you very much, Helena. So I'd now like to introduce to you our first speaker for today. So next up is Jason Ferriggi. Jason is the Chief Information Officer at Outcome Health, and the title of his presentation today is NLP to the Rescue. So
fantastic,
Jason.
Oh, that's great. Hopefully you can hear me okay.
Yes.
Excellent. I'll do a quick share my screen. Hopefully the technology won't let me down. And bear with me and just quickly do. There we go. Hopefully you'll see a Polar Explorer window. Great. And firstly, I'd just like to thank Helena. It's been great working with Monash Partners on this project. We thoroughly enjoyed it and we've got a lot of value from it. So a big thank you firstly. So anyway, let's go through my presentation. Yes, NLP to the rescue. Right, today you have me doing a presentation. I've been working for over 20 years with IT systems and data, both in health services and Victorian government. I basically love all things data. Everyone who knows me knows I'm a bit of a data nerd. I had more hair in that picture, but I didn't lose my hair because of the CogStack project. I just want to let you know, okay? So it's run quite smoothly and we've done a lot with it. But in saying that, you've got me presenting, but it's taken a whole team of people to make this project work. And it's a big thank you to everyone out there from our team and also to Monash Partners team to get us to where we are. So it was a team effort, but yeah, definitely I'd like to give you a bit more of an oversight and a view of what we've done with CogStack. So the agenda I want to take you through is a bit of an introduction to who is Outcome Health. Then I want to kind of give you a definition of our problem and what we wanted CogStack to solve, what we did, the summary of the solution, what we learned, what we wish we had done in hindsight, and of course what we plan to do next. So a bit of an overview there. So firstly, who is Outcome Health? So we're a not-for-profit organisation. We've been in operation for the past 25 years. We have a clinical services side of the organisation, as well as Polar Data. Polar Data is the tech and analysis part of the organisation that's been invested and working primarily with the CogStack project. Polar is a data custodian on behalf of primary health networks. So we work for primary health or work with primary health networks, and we extract data from just over 1,300 general practices across Australia. And Polar is an ecosystem made up of a number of different tools. I sometimes refer to it as a platform as well, because it handles lots of different things. It handles data extraction, so it extracts tool from general practices. It has a point of care decision-making component within general practices to help clinicians. It hosts data, it has data hosting infrastructure. It does data analytics and transformations, and it offers reports back to general practices as well as primary health networks. And it also has links with its research component, Aurora, as well, to use some of that data for research purposes. Okay, so our problem, or what we wanted to solve, is we, as I've mentioned, we extract data from general practice systems. And one of the data fields that we use extensively is diagnosis. Now, diagnosis in general practice is a free text, unstructured field. So there raises lots and lots of problems because our mandate is we don't take identifiable data from the practice, we only take a de-identified data set. So therefore, understanding how we can take that data, protect it because of patient privacy and a whole heap of considerations, because we can't access it, nor do we want to take it out of practice, has been a problem we've been trying to solve for a long time through various different mapping, a very early on NLP piece that we did probably 6-7 years ago. But generally, the problem has always been there. It is unstructured, and therefore trying to make sense of it is something that we really want to do. We have huge data volumes. So as I mentioned, we're collecting data from over 1,300 GP practices. That breaks down to 130 million individual diagnosis records that we retrieve from those systems. And that breaks down to 7.5 million diagnosis groups that we then map to 12,000 SNOMED categories. Okay, so as you can imagine, some of those numbers and those figures keep growing. Every time a new practice joins the Polar family, we extract the data, or and basically there's a whole new type or whole new grouping of how they've basically been able to diagnose things. So just when you think you may have got it down pat and you've mapped every single variation, you'll see a different format because this is unstructured data. Therefore, trying to make sense of it is not always easy. But some of those numbers are quite big. And you can imagine it is very resource intensive. We basically had to have, we did an NLP piece probably about 6-7 years ago that mapped a vast majority, but there's a lot of them that fall into this unknown category. So we need clinicians, their input, to be able to look at those different values that fall into this gray area, make sense of it, and then map it to a SNOMED code set. So if you think about it, you've got 130 million, mapping it down to 12,000 different types of SNOMED texts. Okay, and then you can see some of the top ones that we see in the system: hypertension, asthma, URTI. There's millions of different diagnosis records that come in for each of those. They've been mapped. Getting it to that stage isn't always easy. Hence why we're very interested. We were and we are interested in using CogStack to help solve this problem. So I've got a picture, and a picture is the journey of data. I'm a very big fan of pictures because I think they speak 1,000 words. So if you think about this high level, and I want you to keep this in your mind because later on it'll make sense. So if you think about the GP diagnosis, that green box there, it is entered at the source by a clinician during a consultation, and it can be entered in multiple different ways. It can be asthma infrequent episode, asthma plan. It could be asthma with spelling mistakes. It could be a whole range of different things that get entered. What we do, the value add that we offer at Outcome Health, is we take all that unstructured data and we put it into that SNOMED code right in the middle there. SNOMED diagnosis, asthma. Okay, so all those different variations get to a nice format, asthma. And then we also add value to it by adding grouping structures above that to make analysis and reporting and filtering of data easier. So for example, we have a higher order diagnosis, which will map asthma to respiratory system. Or we also have a chronic disease category that maps it to respiratory. But in the end, it's about trying to take all those millions of records and add in a structure that's going to make reporting and analysis easier for the end user. Now, whether that be the general practice, the primary health network, or for researchers. But that's basically, in a nutshell, the data journey that diagnosis takes from source to analysis to us. Okay, another big picture, a lot to take in here, but this is our solution. And once again, I think it's probably better with a picture because there's too many words here to try and describe it all. But if you look at that report of this image on the right-hand side, first off, that's the whole journey of data in our ecosystem. So you can see that we have a general practice, and a general practice is entering free text diagnosis. What was happening is basically it comes into outcome health, where we have a mapping engine. And basically that mapping engine is saying, we will take this and we're going to put it into a SNOMED code structure. Okay, and then from that, it basically, if it's known, it goes into various reports and analytics and a whole range of things. And remember that picture, it will come in as a SNOMED, it will get grouped into a higher order group or to a chronic disease, which is this path on the right-hand side here. Now, there's a big question, what happens if the diagnosis is unknown? So we don't already have a map for it. And as I said, every time we enter in, our new practice joins us, there's a whole heap of new variations on how they've coded asthma. It doesn't sound like it is the case, but asthma is probably one of the more simple ones. If you chuck in diabetes and a whole range of other conditions, you'll see, I think one record we had 8 A4 pages of variations on how diabetes had been coded in one practice. They're some of the challenges we face. So we've got the nice map stuff, goes to the right, easy. The unmapped stuff goes to the left, and this is where CogStack comes into it. So CogStack, or in particular the MedCat component of CogStack, is taking that free text diagnosis and basically giving us a mapping structure and saying, based upon a confidence, we think this free text diagnosis maps to this SNOMED code. And what it does, it gives us choices and it gives us a confidence interval around it to say, hey, yep, that looks good. Now, this process here still needs clinical expert review. So we still have clinicians, and I'm sure my CEO, Adam, is listening today, and he's one of our chief mappers. He loves mapping data, lucky for us. So the workflow there, high confidence interval, comes into here. It goes into a dashboard, which I'll show you, where it's reviewed by the clinician who then accepts the suggestions by CogStack or can maybe query them further. And then once it's been accepted or validated by the clinician, goes into this central engine, and hey presto, it is now known and basically goes straight through to an analysis component of Polar. So that's the journey of the whole data set. So we still have some clinical interpretation required, but CogStack's doing the heavy lifting by going through those millions of records, giving us a confidence interval, allowing us to filter it by that confidence interval and pass them through to the reporting analytics. And that's workflow 1, workflow 2, and you can see workflow 3 here. And I said, I've just probably copied on the left-hand side here, the CogStack component. Workflow 3 is at low confidence values. And what we would generally do is make them available. They're not an urgent priority, but we will look at them at some other stage when we have some more time available to us. But ideally, the high level confidence stuff is going straight through, being reviewed, straight into the analytics and reporting component of Polar. But in the end, that's basically what we've been able to produce and build with the help there of the Monash team, of how we're now flowing out general practice data of diagnosis in particular. Okay, so this is what we learned. Validation of existing mapping, previous exercises had worked. So as I mentioned very early on in the presentation, about 6-7 years ago, we put a whole heap of diagnosis through an NLP process, and we came up with a kind of our first version of the map. We validated some of that with CogStack, and it looked like it was good. So what CogStack was able to learn from that previous mapping was basically saying, yeah, in most instances, this looks like it was very successful. So we're happy that the previous work, the foundation work, has been validated through the CogStack component of what we're now doing. A solution would be a combination of machine and human processes due to the complexity of the data. So if you remember back to that image, you've still got the clinician that needs to validate it. Okay, just in case. We don't want anything to go through because it's too important. We don't want to get it wrong. So, but it makes it easier. So you could, basically say anything with a confidence interval of 80 and above, put it through, we'll validate it, and you can do it in chunks. But in the end, you still need a human eye over it at the moment, just to ensure. But in the end, if the map's 100%, then it should generally be able to go through. It was more resource intensive than we originally thought. I think projects like this, a lot of people think, hey, I'm just going to wave the magic wand, chuck this thing at it, and it's going to solve it all. It does solve it, but you still need to invest in it with time and effort. There were some tech gotchas. There was some infrastructure issues at the very beginning. We had to learn some new tech stacks, but we were lucky whenever we had those major issues, we're able to reach out to the Monash team and are able to help us sort it through. So it was a great collaboration. Would have been scary to do it on our own. I think having partners in this space is definitely very good, someone to talk to when it gets tough. But in the end, those tech gotchas were able to get through them with the help of the Monash team. And it always takes longer than you think. We're still working on it now, even though the project's getting towards the end. We're in the final stages, but it always takes longer. So you have your plans, probably double them just to be on the safe side, but you will get there. And and it's the caliber and quality of the team that helps you in that journey. Okay, what we'd wish we'd done in hindsight. Overall, we're very happy with the solution. We're wrapped. We think what CogStack is bringing to us, our solution, is going to benefit us in the future. And therefore, straight off the bat, wouldn't change it. It's going to take a bit more time and investment, but we're going to get there. What we probably would like to do is immerse ourselves a little bit more in the technology and the knowledge. And spend more time with the Monash team. The Monash team has a wealth of information, Adam in particular there, and trying to understand a bit more about how it works. Even though we've now got a good understanding, I think you could immerse yourself, spend more time and kind of get your head into it a little bit more. So we'd like to do that because we know it's a complex thing, and if you get it right, it's going to pay dividends. But I think, just understanding that it's not that magic wand, you're going to have to understand it a little bit more than just accept that it's working, especially if you need to do the validation component of it. And lastly, what we plan to do next. So what I'm showing you there is an image of the screen that we've designed to process this CogStack data. So if you think about that journey, that diagram, what we've now got is this image screen here, which is now working, that will feed the output from CogStack and allow us to sort it, allow us to look at predictions, and allow us to map it to us and to apply that map into a SNOMED code set, diagnosis 1 or 2, and more importantly, map it to those higher order groups. So if you think about it, I've said that this section here, GP diagnosis to SNOMED, this is this section of the diagram down here. And basically CogStack is feeding this table here on the left-hand side with all its predictions. And we're able to say, yep, this was the GP text that came through. This is the prediction that's been made. We accept that prediction 1, 2, or 3. We can review it and then basically format it or select it so that it does get the SNOMED value attached to it. And then it gets mapped to those higher order groups. So that diagram up the top right-hand side there is the full journey, but CogStack is the big central part of it, getting it from the free text to the prediction into the SNOMED mapping. And this is an interface that is basically processing this data nightly. As the data will come back from CogStack and be populated, we will then feed the data back so the system is learning. The benefit of this is we learn every time a new GP practice joins the system because there's a new suite of diagnosis. We're constantly adding value to that engine and therefore feeding it back to CogStack so it's learning and becoming better and better at predicting those values as they come in. One day, maybe in Holy Grail, we'll have, all those records will just come in with 100% confidence interval because we've seen every single variation of what can be captured in primary health. Fingers crossed. And finally, that's really it. I suppose for me, we love CogStack. The project has delivered what we'd hoped for. We're very big fans. And as I said, we want to keep working with it, feed the engine, make it smarter and better. And eventually, hopefully take some of that burden off our clinicians in regards to the amount of time they have to spend just doing the validation and the mapping. But overall, yep, very, very pleased.
Can I just say thank you, Jason? That last slide is what's most important. Because that's so rare that you end up with that at the end of a research project. So fantastic and great to see the work you've done. There is some questions in the chat, but I wonder, Anna, can we hold those over to the panel, if that's right? And Adam and others, you're doing a great job, but Chris and others answering the questions as we go. But if we can hold the other panel to the panel, Back to you, Anna.
Okay, great. Thank you, Helena. Thank you very much, Jason. So I'd like to introduce our next speaker is Theo Christian. He's the Analytics Partnering Manager at Alfred Health, and the title of his presentation today is Using CogStack for Clinical Trial Matching. So I'll hand the floor over to you, Theo.
Great, thanks, Anna. 1 second, I'll get my slides up. Okay, hopefully that looks okay.
Yeah, looks great.
Great. Okay, great. Hi, everyone. Yeah, my name is Theo Christian. I'm the Partnering Manager in the Data and Analytics team at Alfred. So what we're going to cover today, I'll start by talking about what our use case for CogStack was, how we approached evaluating that problem. I'll then talk about some of the things we learned along the way, some of the things we wish we'd known at the beginning, and I'll touch on our future plans for CogStack and data science more broadly. So the use case for Alfred Health was clinical trial matching. So we currently have over 300 open clinical trials across 19 different disease disciplines, which is one of the largest clinical trial portfolios in the country. We've also invested in Trial Hub, which is an Australian first pilot that aims to bridge the gap between city and regional hospitals in terms of access to clinical trials. So clinical trial matching typically requires a lot of manual reading of patient records to identify suitable candidates. Most clinical trials have a long list of eligibility criteria, inclusion and exclusion rules. Some of that's available in structured form, but a lot of it is locked up in those free text clinical notes. So our goal with CogStack was to see if we can improve that recruitment process. So the first use case we approached was a clinical trial that was being conducted by our radiology research unit. So they were looking at assessing an alternative course of treatment for patients with hypervascular tumours. They were only aiming to recruit between 10 to 15 people. However, they began recruitment in April of 2020, and so far they've only managed to recruit one person. However, they have identified another 22 as being suitable. So the goal for us was to find patients most similar to those 22 known patients of interest and flag these with the radiology team for manual review. Some of the challenges that we faced, so we typically use ICD coding a lot in a hospital setting for our analysis. However, there is no ICD code available for hypervascular tumours. Many different types of tumours in multiple sites can be hypervascular. It just means it has a higher blood supply. Another requirement for this trial is because they're offering an alternative intervention, recruitment needs to happen either before the patient arrives at hospital or immediately following their arrival. And given the delay in ICD coding, again, we weren't able to use our sort of traditional approaches. As I mentioned, so we only had 22 patients as a reference, which can make model training difficult. And then on a technical side, the Alfred Health has recently embarked on a cloud migration and adopted a cloud-first policy. So we chose to, instead of just using CogStack as it comes out of the box, we implemented it with a lot of cloud-native services. So what did we do? So we did take a bit longer on our initial setup of CogStack. We implemented it in our cloud environment, Microsoft Azure. We're actually this is the first implementation of its kind. So we didn't have a lot to go on at the beginning, but out of that process, we have developed a reference architecture and a code base. So if there are other hospitals or other sites looking to host CogStack in Azure, they can take advantage of the some of that work we put in up front. I won't go into the detail of what this shows, but this is what that reference architecture is, which is essentially just a blueprint that someone can follow to build CogStack in their environment. Why did we go to cloud? Well, probably one of the main benefits, aside from aligning with Alfred Health's technology and future direction, is it allows you to scale up your compute resources and storage resources on demand. So typically what we would do is when we run the CogStack pipeline, we will scale our resources right up. And then once the job finishes, we'll scale them back down, turn everything off, and you only pay for what you use. So it can also often become cheaper as well. There's less maintenance required for a lot of cloud products, as they're often offered as a service. And this last point is sort of around our future directions. It's quite easy in a cloud environment to switch between using a CPU and a GPU. So that does open up a lot of other opportunities for us with some of these larger transformer models that are becoming quite popular. Back to the actual use case. So finding patients. So as I said, our goal was to provide the clinical trial with a short list of patients that they can review for for how suitable they are for their trial. I'm going to go through a couple of slides now, just explain what that process was. So we went through and building this, prediction tool. So the first step was we had to collect some data from our data warehouse. This is what you can see this on the bottom right here. This is all free text that comes from clinical notes. You can see there's a medical progress note, a discharge summary. We have a lot of this data in our data warehouse, but it is almost impossible to use it using our current tools. First step is we get a list of clinical text. We then pass that to CogStack. What CogStack does, and I think Adam will touch on this a bit more later on today, but we use CogStack to perform name entity recognition. And I've just given an example in this image here, so you can see that there's some free text there, shortness of breath and chest pain, and then you can see what CogStack's done for us is on those bottom lines there is it's gone through that free text and it's then mapped that the entities in that text to a standard code. So you can see it's found shortness of breath and it's mapped that to respiratory difficulty and it's given it a code as well. And that's really useful. That's one of the big challenges with free text data. You can have shortness of breath can also be SOB, difficulty breathing. There's lots of different variations. So CogStack allowed us to sort of map all those into a single concept. So we've got the data. Now we've got some additional information about that data. What we've then done is if you look at this top table, we've created the resulting data set from CogStack is a table that has one record for each patient. And then for that patient, we've counted how many times each concept was referenced in their clinical text. So you can see this first patient here, C006826, maybe that refers to respiratory difficulties. We then, to make this more useful for machine learning, we then convert that into, what's called a term frequency inverse document frequency vector. All that means is we've applied some scaling to those values to penalise common words and promote rare words. So, for example, if you think of the word, if you're looking through clinical text, the word patient will be referenced a lot, and so you would have a high frequency count for that word, but it's actually not very useful. So, using TF-IDF, it sort of lowers the importance of that value. If you look here, we've actually got on the bottom left here, we've got the number of columns is 8,383. Given we only have 22 patients, that's a very high dimensional space to try and train any machine learning models. So one of the next things we did was we reduced the size of that data set down. We projected it down into a much smaller, manageable set of dimensions. What we did was we took, for each of those 22 patients, we took the average of their TF-IDF vectors and produced this single row down the bottom, and that was our reference vector. So this is what we then use to compare each additional patient that we review we say how similar is their TF-IDF vector to the reference vector. The idea being we can then provide our radiology team with a short list of patients. So the number of patients that we put through CogStack was around 160,000. That took a couple of hours for CogStack to process. But as coming out of that, we were able to provide this table, which rank orders each patient in terms of how similar they are to the patient's radiology we're looking for. So we provided this to our radiology team, who were then able to go through and say, yes, they were suitable, no, they were not suitable, and log how much time they spent, provide us with any additional feedback, which we could then use to refine our modelling. So how did CogStack perform? So we've got quite a large table here. I won't go through all of the fields, but I think I guess the first thing to call out is the precision, which is a measure of how accurate the model was. So you can see here the current process was around 24%, and we did have a slight increase in the accuracy when we get to our final model here on the right, 33%. So you can say that the CogStack was slightly better than the current process. However, I think the real benefit here is when we look at how long it took CogStack to find these patients. So looking at the current process, there was an estimate of around 216 to 400 hours to find those 22 patients. If you then go across to our other models here, so you get to the end, it took us 25 hours to arrive at that first shortlist. The next measure we used was how long it took CogStack to arrive at a subsequent shortlist. So as new patients come into the hospital, others leave, we need to refresh our rankings periodically. So the current radiology process, it doesn't scale. So it's however long it took the first time, it would take that long again. However, with the models we developed in CogStack, you can see it took between 7 to 10 minutes. And that's because we've done the work up front once to build a model that is able to identify these patients, and then running it again on a new data set is quite trivial. And you can also see down the bottom here, you can see the average cost per patient went down from between $400 to $780 to around $28 to $42 per patient. So you can see there's a significant saving both in time and money. So what did we learn from CogStack? So I guess the first thing to say is CogStack, it provides a great interface for annotating documents with biomedical concepts and then linking those concepts to standard ontologies such as ICD-10, SNOMED, etc. So this provides a really powerful search capability. So we didn't actually use this component as a search component, but it is something, if you think back to that shortness of breath example, rather than having to think of every different permutation of how you could write the patient had shortness of breath, difficulty breathing, you can look up the ICD-10 code or a SNOMED code, and then you can find all of the documents and clinical notes that relate to that phrase or that concept. Something else we found is that there's a lot of additional work required post annotation in order to make use of the data. So after we got beyond the point of named entity recognition, all of that additional work in building machine learning models was after CogStack, and that was something we weren't quite aware of at the beginning. I think Jason touched on this, and I think Adam will as well, but we also found that there was a need to incorporate the ability to incorporate feedback on a model and its prediction. So we send some predictions to radiology. We then want to know the results, which patients were correct, which ones were not correct. We can then feed that back into our model and improve it over time in the loop. This last point, this point here is just starting with a problem first and then finding the technology to solve that problem. We kind of did that backwards a little bit with CogStack. I think the hospital as a whole had identified that there was the clinical trials are quite important at Alfred. but for the data and analytics team, we haven't had much contact with clinical trials to date. And so we were kind of the other way around. So we had this shiny, fancy tool, and we then needed to find someone who had a problem for us to solve. It worked out in the end, but I think that's something that was a learning for us. What we wish we had known, I guess the biggest thing is that CogSack, as Anna mentioned at the beginning, so CogSack isn't a single piece of software. It's a complete stack of technology. So we implemented all of the components of CogStack up front in the beginning, but by the time we got to that end model we were using for our clinical trial, we were only using a very small subset. So I think that was something that if we had have known at the beginning, maybe we could have saved some time. And as I mentioned before, a lot of our effort was spent training machine learning models, which actually comes after the CogStack process, at least in our use case. So our future plans with CogStack. So firstly, we want to complete the radiology trial. So currently, we've used that model for retrospective analysis. However, we're currently running CogStack alongside their current process, and we're tracking it using live data. So over the next month, we should get a feel for how it works in the real world. But beyond that, we have a number of other grant opportunities which we've put in for, MRFF grants and others. But I think more importantly for us, especially in the data and analytics team at Alfred, we want to look towards some more operational use cases. And we want to find a way that we can move CogStack into a more operational funding model to remove the reliance on grant and project funding. And just continue offering it as a service as part of our BAU work. That's the end of my presentation. If anyone has any questions, please let me know.
Thanks, Theo, and we might even do the questions at the panel, but just to say that work that they're doing at King's College around the DRG coding, that's part of their approach to be able to get a sustainable business model. It gives a funding stream for these sorts of activities to mainstream. So we're hoping to work, as you know, with the grants that are submitted with Alfred and others around that. At the moment, most hospitals pay for those of you unaware, pay a lot of money for coding, and then they have an external agency that codes again, and even so it's not very accurate. And the findings to date at King's would be very encouraging. So hopefully that can help you be able to get some funding for it as well, Theo. So if we can leave the questions to the last session, that would be terrific, and thank you for sharing that. Back to you, Anna.
Great, thank you, Helena. So our next speaker is Associate Professor Nadine Andrews, who is a Senior Research Fellow at the National Centre for Healthy Ageing at Peninsula Health. And the title of Nadine's talk is the National Centre for Healthy Ageing CogStack Implementation at Peninsula Health. So I will hand over to Nadine. You may still be on mute, Nadine.
Okay, can you hear me now?
I can, yes.
No, sorry, I just need to change my slide. Okay.
I think, Nadine, if you just got to display settings and the next...
Do I need to flip?
Yeah, yep.
Sure.
That's, yep.
Okay,
great.
Finally got it
Thank
right.
Yes, terrific, thank you.
Okay, thank you. I'm just going to apologise. I'm feeling quite unwell, and so I'm very croaky. So obviously that's why my computer didn't want to unmute me. Yeah, I'd just like to start by thanking Monash Partners for this opportunity, and also to thank the Helix team who put an enormous amount of work into helping us with our project. So I am the research data lead for the National Centre for Healthy Ageing, and I'm presenting this on behalf of Richard Beer, who's my colleague, and he's the technical lead for the centre. So my background is in data linkage and its application to health services research, and Richard's background is in computational engineering. And I'm specifically going to talk about our application of CogStack to research in the area of ageing. So I'll just give a brief overview of the National Centre for Healthy Ageing. So this is a partnership between Monash University and Peninsula Health, and it's centred on the Frankston Mornington Peninsula region. Now, the reason we've set this organisation up down there is that it is an extremely good environment for researching ageing. We have a well-defined geographic area, so a peninsula, which means that most of the people living in the region access their healthcare through Peninsula Health. We also have a very diverse population. So we've got a range of socioeconomic strata across the peninsula, and we've also got a mix of metropolitan and inner regional areas. 20% of the population are aged over 65 years, and we have the highest rates of dementia in Melbourne. So dementia is a specific focus of the research that we're doing. Within the National Centre for Healthy Ageing, we have 3 streams. One of them is the data platform, the other is a Living Labs program, and the third is the creation of translational facilities. So Richard and I are involved in setting up the data platform component. So I'll just give you a little bit more information about what we're doing here. So we're particularly interested in looking at how we can use electronic health record data, particularly within Peninsula Health, but also how we can link that to other forms of routinely collected data for population health research and for informing the delivery of health care. So stage 1 of our data platform is developing a core electronic health record derived data set. And to do this, we've brought together research relevant information from 13 different systems housed within Peninsula Health. So I'm not sure if people are aware, but often in hospital systems, the data at the back end sits in lots of different systems that don't necessarily talk to each other. Peninsula Health is also a little bit unique in that it has a common UR number across its acute care hospitals, but also across its rehabilitation or subacute care hospitals, its outpatient services and its community health services. So we've been able to bring information together from all of those sectors. Our core data items have been identified through a Delphi process with researchers and clinicians, and we're looking at ways of maximising the quality of these items by bringing in information from the multiple systems and internally linking them, which means that we can have really good information regarding the healthcare journey of individuals across systems and across time. We're also in the process of linking these items to state and Commonwealth administrative data sets such as Medicare and pharmaceutical data, and at the moment have curated data on over 800,000 people over 10 years and linked data on approximately 60,000 people. So one of the limitations though of our data platform is that our data is unstructured. Our data is structured. So at the moment, we're relying on information that's recorded predominantly in ICD-10 codes to identify diagnoses. And for our demographic and other information, we're often relying on information that has come through drop-down box type entries. So for example, if you think about gender, where people tick those various components. The main limitation of ICD-10 codes is that it is not always reliable, particularly for difficult to diagnose conditions such as dementia. So we know that for dementia, ICD-10 codes only have about 20% specificity. So a lot of cases are missed. And often these limitations occur because either they're not well documented at the clinician end, so the specific terms required for diagnosing them in the ICD-10 codes are not recorded, or because the coders haven't, I guess, focused on some of these conditions that are often the secondary cause for people admitting to hospital. So we were really, really interested in looking at how we could better access the rich information that's contained in clinical notes through text data, and how we could use this to improve the quality of information that's in our system and the quality of the research that was produced. So I'm just going to talk a little bit more now about how we implemented CogStack into our system. So Richard kindly put this diagram together, so I can't comment too much on the technical components, but I'll give you a brief overview. Essentially, the blue part is our data warehouse, and so as you can see, that contains our core data set. But what we've actually done prior to the CogStack phase is we've pulled the text data in the form of tables or blobs into our warehouse, where we've done some preliminary warehousing on these text data to help improve the accuracy even before we applied the CogStack pieces to it. So the orange part is the CogStack environment. And so this has provided then the key service for extracting text from all of the electronic record documents. And it meant we were able to feed through this various types, such as both Word and PDF documents. At the moment, we still haven't figured out how to apply this to scanned documents, but that's something that we would like to work on, because unfortunately, a lot of the historical notes are scanned in by clinicians. But the other thing that CogStack did is it put all of these into a single searchable store, and it meant that we could look at these documents either within an individual's episode but across multiple systems, rather than just looking at one document at a time, but also gave us the ability to look at these documents for people who may have presented multiple times to the health service, which is often the case with people who are older and have chronic health conditions. And in the future, we're hoping that CogStack will provide us with the ability to do this type of extraction easily and at scale across the entire health service. The other aspect of this then, from a research perspective, is if we can turn some of this sort of text data into structured data, it then gives us the ability to de-identify it once it's in its structured form and release it to researchers in a secure way, which is really important for research. I'm going to talk a little bit now about our first use case where we have trialled this approach. So specifically, we're interested in looking at whether electronic health records can be used to provide better estimates of dementia prevalence than routinely collected administrative data. And so some of this work is also partially funded by an NHMRC Boosting Dementia grant, where we're looking at better methods for prevalence estimates. So the way that we approached this with CogStack was, first of all, we got clinicians and coders to provide input into the types of concepts, so terms and phrases that they might look at or consider to indicate whether or not someone has dementia. So we weren't just reliant on someone writing dementia in the records. We also looked at a range of other terms, I guess fuzzy terms that clinicians might document when they may not specifically want to commit to a sensitive diagnosis such as dementia. So things like memory loss or cognitive difficulties, those sorts of things. So the great thing about MEDCAT is that it was then able to detect these concepts, these 62 concepts within the text across those multiple notes and multiple episodes. We were able to then use that to derive counts of how often these concepts appeared in those records. So for example, if someone had a count of 0, then we would classify them as non-dementia. Whereas if someone had a count of 1 or more, we would classify them as dementia. We were able to do some sensitivity analyses where we could look at potentially people who only had 1 or 2 and see whether or not that was more likely to fit within the dementia or non-dementia, and maybe an indication of early cognitive decline rather than actual dementia. And finally, we've been now in the process of validating this in a cohort that we developed for this NH and MRC grant, where we have 700 people who have either confirmed dementia, so medically confirmed dementia, or medically confirmed non-dementia. So also in research, we often need a high degree of accuracy when we want to train algorithms, and we didn't want to just be able to use this for our dementia use case. We actually want to apply this across a range of scenarios and for a range of conditions. So we saw the need to have a tool or some way of being able to do this efficiently and at scale. And so for this, we actually partnered with Accenture. And the Helix team also helped us a lot with this to develop a user interface for annotating medical documents. And so what we have to do is train sets of data. I think this has already been mentioned by Theo, but it can be quite time consuming. And so you have your training set. As part of the training set, you need to identify the output and then review the outputs and provide feedback on the correctness of the outputs. So the idea of this tool was to be able to do this much more efficiently. And so what we've done with this tool is it provides manual annotation and reviews, and then you can choose to accept or not accept the annotation. It can create management of the project around the annotations, and it can create customizable document hierarchies and variable sets, and also allows people to go back and audit the decision making around the verification with various controls around that. Oops, sorry, I think I just clicked one. Okay, that's what I was after. So this is just a screenshot of what we've been developing. This just has dummy data in it, so it won't make a whole lot of sense. But this is an example of how we might use it to fill out a survey, such as the EQ5D survey, that has different functional components to it. And so what you would do for this person is someone would go in and perhaps look at whether or not someone had mobility problems. They would look for that in the notes, annotate it, but then also provide evidence associated with why that term has been annotated to infer that the person had a mobility problem. In an ideal world, if we were doing this as a research project, we would have, for example, 2 students doing the annotation, and then if there was disagreement around the output, we could then go back and look at the verification for that and adjudicate on the decision making. And we would then do that over and over again and use that process to train an algorithm that could eventually do this automatically. So I guess in terms of next steps, we haven't actually had an opportunity to use the labeler yet, but our plan is to use that within the dementia project as well and see how that works compared to everything else. But we do see that this has great potential for future work. So we've been talking to Peninsula Health about some of their operational requirements. They're quite interested in seeing whether we can use this for real-time detection of staph infections, which is important for their infection control, and whether we can use it for simple coding of emergency episodes, because we know the ICD-10 codes in the emergency data sets are quite poor. Not everyone goes on to be admitted to hospital. So that's quite important for health service planning. In terms of our own research, we have another project on the go at the moment where we're looking at information exchange between residential aged care and hospitals, and looking at whether we can automate some of the transfer of that data by using text data and not just structured data. And also another thing we're interested in is can we automate the completion of something like the EQ5D data for people who are lost to follow up from the health service, because we're implementing this as something that people would normally do on discharge, so that we can have better information than knowing nothing about those types of cases. So in conclusion, I think the positive take-homes from this experience is that it has allowed us to create a unique environment for exploring unstructured data in combination with carefully curated structured data. And we've developed a proof of concept approach for detecting patients with dementia, which is generating quite a lot of interest. And with Accenture, we now have this flexible tool, which we're hoping will help us to scale up a lot of this work. Some of our main challenges were working with an industry partner. So I need to thank Anna for helping us negotiate some of the contractual headaches we had at the beginning. This was a really different way for Accenture to work. They're used to coming in, plugging things together and delivering a product. And so we actually made them work quite hard and went back numerous times to make sure we got what we needed. And we also insisted on it being open source, which is also not the way that Accenture usually operates. So being open source, it gives us the capability of sharing it. I guess the other challenge is that ongoing resourcing. So even with our labelling tool, if we are going to build algorithms and implement this more broadly, you need manpower to be able to facilitate that process. So part of that will come through future grants, and also looking at other ways that may be of value to the health service.
Thank you, Nadine, especially when you weren't feeling well. You didn't sound too croaky at all. To highlight that it's really interesting that you've had the opportunity to work with both an open source, freely accessible, and then with a contract environment. And I know that Anna had quite a bit of involvement there, but also highlighting that that was work that King's really wanted done and hadn't done. So that was an opportunity for the project to give back. And that was part of that 5% of open source innovation that I referred to that's come from outside King's. So it was a really great example of working with industry in a way that came out with an open source product. So just to highlight that that's possible and has been highly productive, and indeed also just shows that you can do it in a way that value adds. So thank you, the learnings there as much as anything else were great. All right, so we've got quite a few questions. I know Adam Morris has been answering them, but I think you're going to Adam now to give a broader overview of the, and I'd just like to thank Adam, because I think this is a bit of a tricky, even before you talk, Adam. It's always hard to have great academics who come in from the university in a primarily research, but also a support role. And Adam and his team have done a spectacular job, which is part of the reason it's worked really well. So thank you, Adam. Over to you.
Thanks a lot, Helena. And yeah, thanks to the other speakers also who've really done a great job of introducing, I guess, the three key stories of this project. Monash partners are driving this project broadly, but at Monash University, we have a team that has been delivering into these 3 use cases that you've heard about today. So I'm a research fellow in the Monash Data Futures Institute at Monash, and I'm one of the people delivering on this CogStack project. My focus is mostly on the NLP and AI aspects. Helena just mentioned that one of the aims is to be able to add things to the existing functionality of the CogStack ecosystem. So partly what I want to focus on in my presentation is what we've done in that sense. And overall, the purpose of CogStack, I would say, is to shorten the path from someone having an idea to being able to actually realize that idea and achieve some sort of outcome in healthcare. We've tried to make that path shorter again, hopefully. And we've done that with our Monash team, which is spread across a few different entities within Monash, the Monash Data Futures Institute that I mentioned, Helix, the eResearch Centre, and a broad team. I just want to particularly single out Fanush, who's done a lot of the technical delivery of the deployments. So what I want to do with my time is to bring together the 3 stories that we've heard today from the 3 partners, Peninsula Health, Outcome Health, and Alfred Health. The Monash team has been primarily responsible for delivering the technical aspects of the CogStack work for the first 2. And Alfred mostly, as you heard, they mostly looked after themselves and had their own architecture for delivering the CogStack pipeline. So we mostly had an advisory role there. But what I want to do is bring together these 3 different use cases and stories and try and see them from within a common framework. And the reason I want to do that is that we've been trying to essentially build a tool that would allow us to answer questions like these ones or address these sorts of problems using a single tool or a single software package that's easily configurable, so that tomorrow when somebody comes to us with a new purpose, we can say, yes, we can use our tool to support that one as well, rather than writing some code that solves this problem and then writing a completely separate set of code that solves this problem. Ideally, we'd be able to come up with a tool that is reusable. So partly that's the aim here. So I'm just briefly going to return to, well, what does CogStack do when you just pull it off the internet and deploy it at your site? It does lots of things to do with getting the data in the right place and getting the text out of the various formats that your data might be naturally housed in. Once it does that, one of its main things is, we've heard a lot about MedCat today. It's a medical concept annotation tool. And I think Theo covered this quite well. Basically what it does is it reads clinical text and it's able to detect whenever there's a mention of a biomedical concept that is familiar to the model. So in this example, there's some clinical text and MedCat has detected this first term here, intracerebral hemorrhage. It has detected that that is a specific way of saying this standardized concept, cerebral hemorrhage. This standard concept is from, I think, the UMLS ontology. So it has an associated code. We know that that concept is of a certain type. It's a disorder. It has a corresponding code number in the ICD-10 system and so on. So that's the main thing you get out of the box with CogStack, is an ability to readily annotate clinical text with biomedical concepts. And by doing that, that's imposing a certain level of structure onto the data. It starts out very unstructured. By mapping it to these standard concepts, you've got some degree of structuring. And these ontologies are very large. So UMLS has almost 1 million concepts in it, and other ontologies have fewer concepts. So that's the basis of data sets that we use for these use cases. And we've implemented the CogStack environment at several sites, as you've been hearing today. We've annotated a huge number of documents, and those documents have in turn yielded a huge number of annotations. So these are the MedCat annotations, concepts. And what we want to be able to do is to take these, this process, these annotations, and go from the clinical text to addressing the specific use cases of these 3 partners. So those use cases, we could broadly say, One of them was about patient classification. Another one was about assigning SNOMED codes to clinical text. And another one was about finding patients for clinical trials. So CogStack provides a great environment to put in text at one end and to get these concepts at the other end. But unless your use case is specifically to annotate text, it doesn't actually get you all the way to where you want to be. There's still a gap here that we have to be able to fill somehow. So if you want to be able to do these things and what you have is annotated clinical text, you could put in some manual effort to get to the endpoint you want to get to. And CogStack does make that much easier. All of the data that it generates gets put into an Elasticsearch database. And so the original raw text and the annotations are all readily searchable, accessible, and you can create visualizations of the data in a browser-based environment with Kibana. So I can show you that briefly here. So this is a view that a clinician could look to if they wanted to, or a data scientist. This is an example of just a raw clinical text that's been put into the database. So you could very easily search the unstructured clinical text if you wanted to, and perhaps you might find what you want. You might also, or instead, search not the raw clinical text, but you could search through the annotations that have been generated by the MedCat tool. So that would potentially be a more effective search because it's much more likely to be able to find what you want, given that it's standardized the data to a certain extent. But, and you can, as I said, you can create fairly standard visualizations and dashboards for specific purposes within Kibana. But in our case, we wanted to try to make this path shorter. So we wanted to perhaps be able to put in text at one end, develop some AI or machine learning that could go all the way from the raw text at one end to the outcomes at the other end. So that was our broad objective here. So to do that, the first thing is to bring these three different stories into a common framework. So to some extent, what I'm intending to do here is to maybe spend a little bit of time on some slightly more technical points of how we do this, and then present some of the results that you've already heard about, but maybe in a different way. So what I've done here is really just, I'm rephrasing each of the use cases to emphasize the things that I want to emphasize. So at Peninsula Health, their interest was in being able to say whether a given patient was more similar to those who have dementia or those who do not have dementia. That was the classification. So the key words here, we care about patients, and we want to compare patients to other patients or this concept of dementia, so similarity. At Outcome Health, the object of interest or the entity of interest were these GP visits and text corresponding to the diagnosis from the GP. So which visits to the GP or episodes are most similar to a new one? If Jason receives a new data point in his system and that we want to be able to automatically assign a code to it, one way we can do that is to say, well, which codes do we typically assign to GP visits that look like this one? So which GP visits are similar to this new case? And again, with clinical trial matching, we might have some sort of prototypical patient that might be determined by the inclusion and exclusion criteria of a clinical trial. And we can say, well, of our patients in our data set, which patients are most similar to this prototypical patient? And so I'm converting these text descriptions at the top to something that's more machine readable. This is more what it looks like in a computer, where you've converted, in some way you've converted the text data or whatever data you have into representations that are suitable for making decisions and training machine learning models. So if we have a new patient, we can say, is this patient likely to have dementia or not? If we plot that patient into this conceptual space that I'm defining without really describing what it is, I think even just intuitively, we could look at this in a cartoon way and say, well, this patient, it's sitting here among these green coded patients, these ones that have dementia. So a classifier would reasonably say, well, we think this patient perhaps has dementia. And similarly, if we have a new GP visit, we can say, well, maybe we should code this one with the code corresponding to a rash, because that tends to be the code that we use for GP visits that look like that one, and the same sort of thing for the clinical trial use case. So our objective is to develop a standard pipeline that can be used so that we can ask a question, specify our source data set for text, specify the set of concepts that we care about, and that involves usually using the ontology, and then putting the data into this format where you can train models to make decisions about the things you care about. So I'm going to start with Jason's example and just go into slightly more detail of how we actually did it. It remained a little bit of a black box in Jason's description. He gave a wonderful description of the flow of data through their systems. The step that's, I guess, missing is how we map from Jason's diagnosis text, so this is the text input here for several examples, to the SNOMED label that has to be assigned to that code. So I'm not going to revisit the whole description of Jason's use case, but broadly what we're trying to do here is to create an algorithm that can take in this diagnosis text and can predict which label we should assign to that text. And as Jason mentioned, there are 12,000 different possible values here. So if we think of this as a classification AI problem, we have a very short snippet of text and we need to choose which one of 12,000 possible labels we should assign to it. So that's a reasonably difficult task. But that's what we're trying to do. And so the way we did it is to, very similar to what Theo described for his approach with clinical trials. The first step is we take Jason's clinical text and we annotate each of those documents using a MEDCAT or CogStack MEDCAT model. In this case, we annotated the document with SNOMED concepts. So what that does is gives us this intermediate column here, which is for a given input text, we end up with a list of annotations for that text. So in each case here, we've got one standard SNOMED concept separated by this pipe here, and then another SNOMED concept. We then use the annotations as the basis for our machine learning step here. So we're not using the raw text in this machine learning step here. We're relying on MEDCAT and the AI and machine learning that's built into MEDCAT to process that initial text, but then we do some further custom machine learning at the back end here. And the purpose in doing that is to go from annotations to decisions about which label we should assign to this text. It's like a global classification rather than the sort of word level classification that you could say MEDCAT is doing. I'll skip some of the detail here. Each step here is very similar to what Theo described in how he processes the annotations to end up with a result. The only key point, if you're familiar with it, is in this case, we're trying to choose one of 12,000 possible labels for each case. And we do that using a k nearest neighbors classifier. So here's an example of some of the results we get for these examples. So what I'm showing you here, if we just take one row, this first row here, I'm showing you the top 5 predictions that come out of our algorithm. So our model thinks that the most likely code that Jason would assign to this, this particular case is upper respiratory tract infection. Turns out we were wrong. That's not the label that they used. They used sinusitis, which is perhaps a synonym, by the way. Our model did pick up on sinusitis as being a reasonable answer and put that as its second most likely prediction. So from left to right here, we've ranked our model's predictions from which ones it considers most likely to least likely, and I'm just showing you the top 5 here. Remember, there were 12,000 possible outcomes, so we're just seeing the top 5. So here we're seeing 3 hits, you might say, 3 correct for our first prediction, 2 incorrect. One of the ones that was incorrect, we nearly got it. The correct answer was second in line. The final one, we really didn't get close at all. So this is a summary of how well this algorithm is doing at making these predictions. So what I'm showing you here is the percentage correct, how well we're able to predict the label that Jason at Outcome Health would manually assign to these cases. But I'm showing you that as a function of the model's confidence. So the model itself has some insight into whether it's likely to be correct or not. And we can see that down at this right-hand end, when the model thinks it's correct, it actually is correct most of the time, somewhere around 80% of the time. And when the model really says, no, I'm more or less just guessing, the model performs very badly and is probably not much better than just guessing. Overall, across the full data set, it's getting the answer correct. So our top prediction is the correct one roughly half the time. And the correct answer is in our top 5 predictions, maybe 2/3 of the time. So it's not perfect. It's certainly not an algorithm that you would want to just press play and let it run unsupervised, which is exactly why Jason described a workflow that involves clinician review of these predictions. But certainly if you compare these values to what you would get if you were just guessing, at best, if you were guessing, you would get maybe 4% correct. So it's doing way better than an algorithm that just rolls the dice and chooses randomly. So what do we want to do with this? Well, Jason's already gone through how this sort of approach could be integrated into their current workflow. We can also use it to analyze the historical data set. So we can use the same model to identify perhaps when there might be a data point in their data set that has perhaps been coded incorrectly. So if you've got this outlier here, that it might just be an unusual case, or it might be that actually the algorithm has detected that maybe something's gone wrong here and we should correct that annotation. And the second step is really the one Jason described of being able to automate this process, or at least have it as a semi-automated process. Now, Peninsula Health, we used a very similar process. I'm not going to go through it, but broadly to say it's kind of the same, and we can put a classifier on the end. So just in this last minute, I want to sort of reiterate this point that what we've done, we've used Medcat as intended out of the box. We're annotating documents, but we've developed a package that allows you to ask questions like this and to, in as easy way as we can currently think of, to specify your project in a very simple way that allows our code and our framework to perform these sorts of classifications or rankings or search that we've talked about. And for that to happen more or less automatically with minimal involvement, so that the overhead for clinicians or data scientists within the healthcare system to be able to pick this up and do something useful with it, to lower that barrier to entry and make it as easy as possible. So in that sense, we've done that by creating some new repos that we eventually would like to feed back into the King's College CogStack ecosystem. We think this could be a useful additional service or script or framework that can exist in the environment. Basically, it just allows someone to specify a new project. All they would really need to know is how to fill out an appropriately formatted JSON file. And the way we do that is we've built a wrapper for a very popular machine learning package, a Python-based machine learning package, that allows you to do a lot of quite flexible and standard machine learning operations and inferences on the basis of CogStack's output. But to be able to do that with very large data sets and in environments where you might have very limited computational infrastructure, which is certainly true for many healthcare settings. So it does a lot of the things we've talked about and is ideally very easily configurable. So that's basically the end of what we've done. We're now evaluating how this new tool can work and being able to try that out for some new use cases. Some of the things on the horizon would be using something like this for near real-time use in clinical settings. Again, everything we're talking about today is all proof of concept, sitting in a research environment. None of what we've described is in production or being used for healthcare or even sitting directly in the hospital infrastructure. It's in sandboxed environments. and some other administrative improvements that we would like to do. And as I think Helena has mentioned already, there are many new funding applications that are already in place that are hoping to continue and expand on this work. So I'll leave it there and back to Helena.
Terrific. Thank you, Adam. All right. So in the last 15 minutes or so, we will tackle some of the questions that we held over. So I might circle back to, I'll start with a few questions that have come up in the chat, and then I'll move across to the Q&A. So Jason, we have a question. Someone has asked whether or not you could expand more on some of the technical gotchas you encountered.
Yeah, fantastic. Definitely. I suppose the first one was the environments. We're primarily a Windows-based operation, but we had to run the Medcat CogStack on Linux. So it was just a bit of an operating system refresh and upgrade to kind of get us more compliant with what we needed to. So that was the first gotcha. The second one was probably around the resourcing to make the engine work. There's a lot of processing and churn that needs to happen. So therefore, just getting that right so that you're still going to be waiting because it's a lot of work being done, but ideally the more grunt of the server or the output machine, the better the output and the quicker. And in the end, what we wanted to do is, because we want this to be kind of part of our nightly routines, we want this data to come in, be processed as quickly as possible and make its way into our reporting environments. So, or get it at least ready for validation by that clinician, which is that kind of manual interpretation of it all. The other kind of gotcha was how to integrate everything together. So you think about the ability for us to, and this is a typical ETL process, where you're taking data, getting it into a format to give it to CogStack to consume. CogStack does what it needs to do in regards to Medcat in this instance, and then gives it back to us in a format that we can consume again, put it back into its process. So they're the processes. So that's so technical from a bit of hardware infrastructure and processing power, but other than that, is also that kind of gotchas around how do you make this all work and hang together so it's sustainable. Hopefully that's a little bit of insight there.
Great, thank you, Jason. Just looking in the chat, there was one question: Can CogStack interpret coding other than SNOMED? Sorry, Adam, I know you touched on this in your presentation, but did you want to elaborate any further on that?
Right. So the essence of how Medcat works is that you start with a standard biomedical ontology like SNOMED or ICD-10 and so on. You feed that ontology to the model, and then you set the model learning, unsupervised learning, on a huge cohort of clinical data. It then trains itself. It doesn't need any supervision. Just using its knowledge of the ontology, it's able to learn from clinical text, and then it's able to annotate clinical text within the concepts that were within that ontology. There's nothing special about the data format or the ontology in feeding that ontology to the model. That you could have an ontology that comes from a completely different domain, like auto mechanics, and put that into Medcat and train on a large data set from the mechanics industry, or really wading into territory I know nothing about here. And it would learn those concepts. So the only thing it really needs is an ontology on which it can teach itself the linguistic structure of text. And so it's really open to any of the standard ontologies that are used worldwide.
Great, terrific, thank you. So we had a question early on asking, does CogStack work with all EMR systems integrated? Does anyone want to tackle that or have any views?
Maybe I'll have a crack at that. So my understanding, and correct me if I'm wrong from my discussions, is that in most cases, they're not actually integrated into the EMR, they're integrated into the Azure or the cloud platform where the data is actually stored. But it can be integrated into EMRs. The problem really is the product providers and whether they actually want the product into the back end. So in most cases, the data lake or the data storage, which is in, for example, in the Alfred's case, correct me if I'm wrong, Theo, updated pretty regularly, almost real time, so 15-minutely. And that sophisticated system allows the team, Theo and others, to integrate it into their data lake rather than into their product. But my understanding is the barrier is not the products, so it can be integrated in any of them, but it's the problem of the providers. Adam?
Yeah, I think that's right. CogStack doesn't really directly interface with.
Oops, you've frozen. Hopefully we'll get Adam back in a minute. Did you have any comments while Adam was coming back, Theo?
No, I think if I'm guessing what Adam was going to say, CogStack, like you were saying, it's pretty platform and product agnostic. And this is something that we found is it's this really great tool for extracting information out of text. But what you do with it then is really up to you. So you can train machine learning models like we did. You can maybe, if you did want to use that biomedical concept search capability, maybe you build a web page where you can go and something like similar to Google. You can search for particular concepts. There's probably unlimited applications for it. It's really what you want to do. I think I know at the Alfred. I think it might be a few years away, but integrating some of these predictions from CogStack models, feeding that into Cerner, which is our EMR, is something that would be really interesting to tackle. And it is definitely possible. I think there's probably a technical component to it. But I think maybe more than that, I think, yeah, because with machine learning models that there is going to be some margin of error. I think that overcoming or building confidence in the model with clinicians is probably one of the harder challenges, I think, to overcome. Yeah.
Definitely, Theo, and I think that's why the use cases that you've all got are spectacular examples, because they're early detection and feeding into disease etiology. They're clinical trials where you can afford to get 3 hits for every one that you want, because you've got a second screening process by a human. The days of being able to use the accuracy that Adam talked about to actually guide clinical practice are way away, not the least of which is there's many ethical and other barriers before we get there. But there's also opportunities to think about. There are much more conventionally developed risk prediction models on structured data that can be integrated into EMRs first, I think, before we get to these sorts of AI models. Adam, do you want to finish what you were saying? Sorry, you froze.
Am I sufficiently back now?
Yes.
Sorry about that. Really, I was just saying that the front end of CogStack doesn't directly interface the EMR at all. It just interfaces a data set that has been provided to it. So it's up to the hospital IT staff or research team, whoever it might be, to extract the relevant files or data from their databases and put it in a staging database for CogStack to ingest.
Thank you very much. And there's a couple of other, Anna, you got some more questions?
Yeah, sure. So we've got a question here from Grant Russell. So how does the system deal with something that is the essence of primary care, multi-morbidity, in particular when numerous clinical issues are dealt with at one visit?
Yeah, I suppose for me, well, yeah, it's an interesting question. And, like when you think about primary care, the way clinical information systems are designed, everything will get kind of blobbed into, and as Adam demonstrated, you'll sometimes get 3 or 4 lobbed into one string of text. There's no concept of a primary or secondary diagnosis like there is in a health service, where you've got a nice primary and 1, 2, 3, 4, 5, whatever it may be. So for us, that's what we're really hoping CogStack can help us fix, because as Adam said, you can see where it's uncertain, but it will break them up into its various different sections and allow us to basically then chunk them up and to put them into the proper grouping, so that, and there's no reason why for one particular presentation or an episode of care within primary care, you can have a one-to-many diagnosis relationship, and that will be collected over time. The other really interesting concept about primary care is that episodes will go a lifetime. You know, you might be seeing the same general practice GP or general practice for your whole life. So there's not like this nice admitted, discharged, you know, view of the world that you see in health services. This is very much a lifetime of data that's collected, and therefore collecting all those different diagnoses as you go through that life stage is part of the parcel, but there is kind of no primary or secondary view of it. It's just all your diagnosis. There is a concept of active and not active. So they will be flagged as an active condition within the system and sometimes a non-active diagnosis. So that's the only kind of difference that you'll see in most of the CISs in the primary care space. Hopefully that answers that.
Thank you. Adam, did you have some thoughts?
I just want to add one thing to that, which is, I guess one of the maybe the nice features of the algorithm that's making those predictions, it's not trying to achieve some objectively correct answer. It's actually trying to just mimic what Outcome Health have been doing. Whatever it is Jason and the rest of the team do when they decide on a primary diagnosis. So in the case of a GP visit that has clearly several different things going on, somehow they're able to identify what their best estimate of what the primary diagnosis is. And our algorithm is trying to mimic that same reasoning. It's not trying to be objectively correct. It's trying to mimic the manual process.
Yeah, and that's taken the best part of 7 or 8 years and constantly learning. Once again, a call out to Adam, my CEO, who's done the bulk of that mapping from a clinical perspective with other clinicians over the years to get it to where it is. So it's a lot of work.
Other Adam,
exactly. Adam McLeod.
And really important that we really appreciate Outcome Health coming on board, because we've got a lot of learning from your end to be able to share as well. So terrific. Anna, any other questions?
Yeah, so there's a question here. Can CogStack incorporate structured as well as unstructured data?
I think the answer is just yes, isn't it? I think we can pretty much just say yes.
Yeah, okay, great. Another question is, can you share some of the learnings of moving PHI data to public cloud, especially the privacy, governance and regulatory aspects? So perhaps Theo, did you want to tackle that one?
Yeah, so I think I've been keen on moving to the cloud for a number of years, but I think it's only recently that there's been an organisational shift in terms of its comfort with moving to the cloud. We have had to go through very rigorous, the implementation that we did at Alfred has been done very hand in glove with the security team at Alfred. I can't speak too much to the overall governance of it. I think cloud.
I could just add on that, it still remains behind your firewall. So one of the big issues, and we've got a consumer and community involvement group who have been involved in this project and who've fed back in about the whole concept of AI and their comfort levels. And one of the big things for them is it's Alfred Health data. Obviously it's consumer and community data, but it's held by you as a governance context. In terms of when I say behind your firewall, you still have the security and governance over that data where you store it. You're not putting it into a shared environment that other people can access, as I understand it. And that's the same with CogStack, and that's the same Nadine and Jason with you as well. And so at least our consumers, if that's correct for you, our consumers don't see any problem with that at all, actually, as far as they're concerned. If the data is stored as a secure form of data storage for the data custodian, as long as it's the data custodian that retains the governance, what specific form that is, as long as it meets privacy requirements and isn't therefore shared just because it's using that stored platform, they don't have a problem with it. Is that consistent there with your understanding of the way you've got your cloud access?
Yeah, it is, absolutely. I think what we're doing with the data in the cloud is not any different to what we'd be doing with it on a physical infrastructure. And it's probably more secure because the servers and the data center that the data is stored in is managed by, in our case, Microsoft, a very large company with millions or billions of dollars to spend on research and development. So I guess it's probably, I would think, probably more safe there. It really does come down to what we're doing with it, and that doesn't change whether it's on-prem or cloud.
Thanks. And just also to add that somebody asked before about whether that does involve any of this involves any transfer of data to the uni. It doesn't at the moment, but there is the next project we've got going in that Adam and many others are involved in, that will actually happen. So there'll be big tranches of data that will be transferred to the secure e-research platform at the university, and CogStack and many other tools are integrated into that platform, which is pretty spectacular actually, and ISO 11 security accredited. So that will allow us to share data across multiple health services for the purpose of healthcare improvement. So that is part of the next step. I don't know if Jason and Adam or Nadine, if you had any comments about that question about the environments.
Yes, so I can just, I guess, provide a little bit more if the interest is around release of the data. So we're processing everything behind Peninsula Health firewalls, but what we're aiming to do is do the unstructured CogStack component between the firewalls, but then create outputs that are structured that we can then de-identify, which means with ethics approval, we can release them externally to researchers.
Terrific, thank you. Just in the last couple of minutes, so thank you, Adam. I can see you're responding to that question. So Chris Bain had another question about the data input is always a push ETL paradigm for now. Question for Adam, Jason.
Yes, so yeah, you're right. So we push the data into CogStack, so we extract it, get it into a format, and push it into the tool that then outputs it, and then we suck it back into our processes. So yeah.
Great, thank you. So Theo, you mentioned several of the CogStack components weren't required in the end. Can you elaborate, please?
Yeah, sure. So I think one of the, so really all we ended up using, all we really used was the Medcat library, which is a Python library. So at the end, that was really the core part of what we used. Some of the other components, so for example, Elasticsearch, when you set the default operating environment for CogStack is to store all of its data in an Elasticsearch database, which is different to a SQL type database. It's very useful for fast searching and retrieving information. But I think in our use case, we are using that. But I think moving forward, some of that might get siphoned into a SQL database, which we're a bit more familiar with and integrates better with our environment. Kibana was another component. So that's the that user interface that Adam had up, which you can use for dashboarding and some of that interactive search. We didn't have a use for that. We did create a dashboard for radiology, for that radiology team to view all of the information for the patients in a dashboard, but we did that in Power BI. But I think that's kind of the nice thing with CogStack is it's this broad range of components. You can kind of pick and choose the ones that you need.
Yeah, and I think also too, to clarify, correct me if I'm wrong, Theo, but you were actually able to, rather than using native CogStack products, you swapped them out for complementary Azure services. So you still had sort of that overall architecture, you still had all the components, but you used ones that Microsoft had the same, I guess, offering. Yeah,
exactly. There's Apache Tika, I think it is, which is the ETL tool. We replaced that with Azure Data Factory. This is the same function, it's just a different product.
So can I just, on that, I think that's the point about this being open source, innovative and able to adapt. And we've met with many other, I suppose, commercialized products. There's lots of them. And the user cases that so far that we have been able to see and interview people don't have the ability for you to do the very substantive tailoring that you've done. The commercial product argue that they can provide something that's more developed or potentially trained, etc., and that you won't be able to implement it. But clearly the capability here across the university team with Fanush, Adam and others, and your own capability internally has actually showed that you can. Which is terrific, and I think the open source model really offers that advantage, plus the great example of Nadine's work where you've had a private contractor come in and still make that open source. So can I just wrap out, Anna, if it's possible, just a couple of quick things. Thank you to everybody. Brilliant. Grant Russell's comment, thanks everyone. I really finally understand CogStack, really said it all. So thank you. We really appreciate working with you all, and we will be continuing to support this work. Now, I want to say a special thank you to Anna, who has done a great job of managing the project, and I think everyone really appreciates that. Also wanted to acknowledge Joanne Endicott and Alison Johnson's phenomenal input into the Learning Hall system and to this work as well, and to all of our partners and the great interactive audience. And if you've got other questions, please reach out to Anna and she can direct you to the right people or directly to the people there. And as we noted, whether or not we get funded, we will continue to support the work across the partners, and we'll be coming back with greater opportunities for from King's as well. So thank you, everybody, and a great afternoon. Thanks.
Thank you. Thank you.
Thank you.
Thanks, everyone.
Thank you.